It's a real pleasure to introduce Tamsin Ford. We've known Tamsin for a long time, and she's even done some work with a number of us in Oxford. She's Professor of Child and Adolescent Psychiatry at the University of Cambridge, and took up her job just before COVID started, and actually in the middle of COVID was appointed head of the whole Department of Psychiatry. So congratulations on all of that, Tamsin. Her academic work has focused on the effectiveness of interventions and the efficacy of services in relation to the mental health of children and young people, and has a particular focus on the interface between education and health. She began her academic career at the Institute of Psychiatry, where she got a PhD, and then she moved to Exeter, where she set up the Child Mental Health Research Group, where she became Professor of Child and Adolescent Psychiatry, and then, as I said, more recently has moved to Cambridge. The topic is very highly topical, as it were, and she's going to be talking about the mental health of children and young people during the COVID-19 epidemic. Please, if you wouldn't mind putting questions into the Q&A, there's no chat available for questions, so just into the Q&A, and I will keep an eye on that. So thanks very much, Tamsin. I very much look forward to your talk.
Thank you, Alan, and thank you to all of you who've taken time to come and listen to this today. It's always a pleasure to speak at Oxford, and so many great colleagues who I've known for more years than I'd care to remember. So my brief is to talk to you about the impact of the mental health of children and young people during the last 18 months. And I'm going to spend quite a lot of time talking about our national survey programme, because I don't think they're as well known as they really ought to be. They also span my research career. So my very first research job was as a clinical rater and also supporting the development of the DORBA back in the late 90s. And these surveys are among the biggest and best for a number of reasons in the world in terms of estimating the prevalence of children with impairing mental health conditions. So the first survey took place in 1999. There was a follow-up sort of 20 months once we'd got funding for a full interview follow-up 3 years later, just to try and keep everybody in touch. The whole survey was repeated with a new sample in 2004 with a couple of follow-ups this time. And then there was a big long gap until 2017, despite the adult mental health survey going ahead in 2014. Children don't vote or lobby their MPs, and it took a lot of pressure to get this children's survey. And we should have had a 3-year follow-up. They were commissioned to do that and to link to the National Pupil Database, but for various reasons it didn't happen. However, we have managed to get some questionnaire follow-ups last year, and there will be a couple this year, and obviously I will talk about those. But I think it's important to say that actually children and young people's mental health in the UK was not in great shape before the pandemic hit. So if we want to understand where we are now, I think we need to think back to where we started. So the graph on the screen at the moment shows the prevalence of any impairing mental health conditions, all of them lumped together, across a slightly odd age span of 5 to 15-year-olds in the 3 surveys that I've just talked about. 1999, there were 10,500 children. 2004, they were just shy of 8,000 children. And then in 2017, the whole sample was actually over 9,000, but it was about 6,000 in this age range. And the first sample was 5 to 15 because the funding came from DH, and they felt that because the adult survey went from 16, that they couldn't possibly do 16-year-olds twice. Fortunately, we've had a bit more flexibility because it's actually a very difficult age span. It just doesn't fit with what anybody else does. And what you can see is there is a small deterioration amongst school-age children in mental health over that 2-decade time span. It's almost entirely explained by an increase in anxiety and depressive disorders, with behavioural and ADHD difficulties staying the same. For those of you who aren't epidemiologists, and something that I think we really need to think about in the current context, is that vulnerable groups are vulnerable. So what you are looking at here, I'm hoping you can see my cursor, is a children's looked after sample that used the same methods and took place after the first 99 survey against the most deprived in the 99 survey. These were people, children living in households where nobody was working and the family was surviving on benefits, and then the rest of the 99 sample. And I think the graph speaks for itself. So massively increased prevalence of a clinically impairing mental health condition in these children who were looked after. And one of the sad things about these children, having worked clinically with this group, is that their histories get forgotten. So we didn't, in fact, have a lot of background data to compare across the samples. But for those we did, they were much more likely to have risk factors such as a learning difficulty, a medical condition, special educational needs, etc. However, being looked after itself was an independent predictor, which should give us some pause for thought. A common comment when I meet people socially and they find that I'm a child and adolescent psychiatrist, if they haven't run away screaming, is that, oh, children don't need psychiatrists. Well, I think I'm preaching to the converted that actually, sadly, many of them do. But the comment is, oh, well, this is just a phase, isn't it? They would get better anyway. Well, this is data from putting together the children with a mental health condition in 1999 and 2004, and then looking to see how many of them still met diagnostic criteria 3 years later. Now, I've got quotes around persistence because we have essentially two snapshots and we don't know a lot about what happened in the middle. But like the Isle of Wight study before us, what we show is about 50% are still meeting diagnostic criteria 3 years later. These are not transient or mild conditions. And the other thing that we need to bear in mind is that excellent work by Ruth Sellers from Cardiff has hinted that certainly if you have problems in childhood in the current century, your outcomes in adolescence are worse than they were for the Ausbach cohort born in the 1990s or the 1970s birth cohort. So we were not in a great place in terms of child and adolescent mental health in our population in the UK. Predictors of persistence are also something that we need to think about in relation to the pandemic, because they give a clue as to what might be a target for intervention. And what you can see here is peer relationships come out as really important, and also the impact on families and parents. The other thing that the psychologists in the audience will be inwardly cheering. Those of us who are medics are dumb doctors. We're taught that you have a disorder or you don't, and we can only count to one, but actually the reality is that there isn't such a distinct boundary between those who meet diagnostic criteria and those who don't, and often it's their social, community and psychological resources around them that will make the difference in that blurry boundary between not being able to cope and having a disorder, or being able to cope despite the fact that you're in a very challenging circumstance. And what you're looking at here is the self-reported strengths and difficulties questionnaire, the parental strengths and difficulties questionnaire, total difficulty score, and the teachers of the same, all taken on the same children in 2004. And it's fascinating because the curves are so different, despite the fact that they're all asked the same questions. So now to the brief for today's talk. What do we know about the impact for children and young people across the world, but more specifically for those of us who work in the UK? What can we do about it in our own context? the first point to make very forcibly is that there is a real data gap for children and young people, particularly those under the age of 16. So some of you may have seen me present this slide before, but this is a heroic living systematic review. And in fact, it went up by 88 abstracts overnight last week when I was looking at it for this talk. So since March of 2020, this team in McGill have screened over 50,000 abstracts and titles for these 3 systematic reviews. The second one they stopped in September because they felt that their resources were too stretched, but also the quality of papers was really very poor. And so they've concentrated on measuring changes in mental health. They're measuring by changes in symptom levels or the proportion of participants scoring above a cut point, or if there is a predefined magnitude, sort of equivalent to a minimally clinically impairing difference that you might be familiar with in relation to randomized controlled trials. And it's got to be across a delineated COVID-19 event. So it could be before and after COVID, around lockdowns, etc. And they're excluding studies with fewer than 100 people because in terms of population-based epidemiological studies, those are just too tiny. So they have a preprint, which you can access via their website. This is across all ages. Initially, they were going to exclude children. And I feel slightly guilty because I declined to get involved because they weren't doing studies to do with children. And then when I went back, they are now doing studies between children. So I feel a bit harsh for not diving in. So in March 22, using data from 36 studies, 33 separate data sets, they report no major indication of change except amongst anxiety symptoms, which increased by a standard mean difference of 0.27 amongst people with pre-existing medical conditions, which is really interesting. But these were mostly on adults, as you can see. So review 1, they have included 100 studies out of the 53,500 abstracts screened. Only 7 of those relate to children and young people. There were 3 studies that had data from March to June, and then again later in the autumn, September to November. And what they found was if there was an increase initially, it had largely dissipated by the second assessment. They have got some studies on children. The sample sizes range from 200 to 2,500. The mean age is 13. There were 2 from China, 2 from the USA, 1 from the UK, which is CoSpace, Kathy. So I'd be really interested in your view of how they've interpreted your data, because I'm not sure it fits with mine. 1 in Spain and 1 in the Netherlands and Australia. They say that these show very little change, including CoSpace, where they seem to have only looked at the emotional symptoms on the SDQ only. Maybe that's because everything else is measuring anxiety and depression. 1 of the studies showed an increase in depression and 1 showed no change. There were 2 others that had anxiety and 1 with loneliness as the primary outcome, and these showed no change. And then there were 2 additional studies that looked at parents. 1 of parents of children with intellectual disabilities, and these were both in the UK, didn't find any difference. And 1 of parents of under 13s, where they reported an increase of caseness on the GAD-7. Probably some of the best data is related to the national survey, and I'll share with you what I can in a minute, but it's of note that the 2017 data has only just been released for people to apply to analyse. And to give you a sense of how long the application process can be, a fast-track analysis, a fast-track permission submitted in mid-December is about getting to commissioning committee level now, and this relates to COVID work and should have been fast-tracked. So it's not a fast process, but I would urge people who are interested to try and access these data, because there's so much more than the brief summary, careful summary that was done with really not very much complex analysis at all. There's so much more we could learn from it. So there is a data gap worldwide in relation to children and young people. Loads and loads of studies of university students, but of course they're a particular group, and I'm not sure you can extrapolate down to children and young people. Oxford holds the distinction of having two extremely good and useful data sets relating to mental health in the time of COVID. So Kathy Cresswell with CoSpace is one. I'm not going to talk about it in depth because I know, Kathy, you have probably done so in this forum before, but for anybody from outside Oxford who's not familiar, I would really encourage you to go to the CoSpace website and to have a look at the UK, but also international work that's going on. It's really excellent. Also from Oxford is Karen Mansfield and Mina Fazel's work via schools, the Oxford Schools Survey, which took place fairly well as the first lockdown was shutting down. And again, I know that Karen has talked about this in depth, so I don't intend to repeat a lot of what she said because I went to that seminar, but I just wanted to use it to highlight the fact that we shouldn't assume that everybody's experience is negative. And this has come out through a number of studies, but you can see here that while more of the older young people, so students in sixth form in years 12 and 13 are saying that lockdown has made them less happy. There's a small but significant group who have said that actually it's made their life better. And I think we need to understand better what that's about. What about change pre and post COVID? So this is data from Emily Widnell, who's a PhD student in Bristol. She had gone into schools around the Bristol area just in October of 2019, and therefore was able to go back to the same schools to collect more data. So this is pre and post the onset of the first lockdown last year, and over 1,000 students aged 13 or 14. And again, it's really interesting. Overall, there wasn't a change in mental health. But if you cut the scores that they were using, and they had a depression score, which I'm showing you, but also an anxiety and the WEMWEBS, the wellbeing scale. If you cut those by established cut points, so you had children who were struggling with their mental health pre-lockdown, they were actually doing better post-lockdown. And that was replicated for anxiety, for depression, and for wellbeing, which should make us pause and reflect if children with poor mental health were actually doing better when they're not having to go to school. What on earth is going on with our school system? I also wanted to flag up this preprint, which I think is interesting. It's not without its problems. It talks about international changes. In fact, it's 10 studies from the USA and one from Peru and one from the Netherlands that had data pre-COVID and went back to the same samples. Some of the, excuse me, some of the pre-COVID data is really kind of pushing the limit. 2015 is a long time before. Most of them were much closer, mostly 2019. Also, an epidemiological sample of 38 isn't really an epidemiological sample, and I'm not sure what it really it can tell you. And only half of these were community samples. So I think they would have done better to write up their community samples and perhaps not be so data hungry. They were all followed up in April to September last year, and some of them more than once. And what they showed was a significant increase in depressive symptoms. No change for anxiety. Younger children were less likely to be anxious, but there was no age modification of depression. And there was no association between the mortality rates in these areas at the time the data was gathered, but there was with how strict lockdown was. So there is a hint that this was related to lockdown restrictions. Interesting, needs replicating with better methodology. And a similar opportunistic study. This is a control group from a study in Cambridge, children attending local schools who are, were normal controls for children who were struggling in school. They are on the affluent side, only 8% eligible for free school meals. The national mean for free school meals is about 18–19%, but they're quite young to be demonstrating an increase in depression, which is what they found. So they were 8.5 before lockdown and 10 during lockdown. And interestingly, the anxiety and depression measure was the ARCADS, the revised Child and Adolescent Anxiety and Depression Scale, which has many more items on anxiety than it does have on depression. So I think it's very telling that it picked up a change in depression. Although I do think we need to think about the wording of some of the questions. So for example, a lot of adult studies have used the general health questionnaire that has a question that says, cannot do your usual activities. Well, I think many of us would answer, particularly in that first lockdown, yes to that. But actually it wasn't that we didn't want to, or we hadn't got the motivation to, it was that we actually weren't allowed to do that. But it's really interesting. So there are hints in some of these studies that maybe depression is an issue, and maybe in very young children. So we did, as I said at the beginning of the talk, managed to get some funding and managed to get the Department of Health and to commission a follow-up, and then we got some funding for it, and that involved mobilizing NatSen, the Office for National Statistics, as well as the academic colleagues. So we collected information in July of last year. We went back to all of those who'd responded in 2017 and allowed us to recontact them. But of course, over 3 years, there's been no keeping in touch exercises. So we know, the response rate is disappointing, but it's not unexpected when you haven't tried to keep the cohort together. And I guess the saving grace is that we know an awful lot about those who didn't participate, which allows us to weight back to the general population. So we also have some additional funding, which is out with the survey program. So we will be sampling from the 2020 interviews to find out more about lockdown experience. And I think there are several groups doing this, and I think it would be really interesting to see what they all find. So we'll sample across to get the breadth of experience from those who are, saying whether lockdown in the questionnaire made their life much worse to much better, to find out the circumstances that play into that. And we are also investigating service contacts in relation to those 2020 interviews. And those are literally about to start now, to give you a sense of the permissions progress that you have to go through to get this work done. Then there was more data collected in March this year, and we've deliberately sort of didn't tie in what we would do interviews about so we could be responsive to policy. And of course, the that allows us to kind of pivot to what the need is. So what we will be doing with those interviews, which hopefully, because we've been through the permissions process, will be much quicker to get online, is we're going to complete the diagnostic assessment, the development and wellbeing assessment that was completed in 2017 for those that look like they might have eating problems. So we couldn't put the whole module in a 20-minute questionnaire. But what we could do is put the screening items from the DORBA into the questionnaire, and then anyone who screens positive, who, you know, in 2017, or if it was being done as a face-to-face interview, would then proceed through the module. We will complete the module with as many of them as we can. The other thing that we're going to interview on is children with special educational needs in terms of provision, which I think anecdotally through parent groups and things, I'm hearing really mixed pictures. So I think that's really important. And then the third strand of work is with Johnny Downs at King's College London. We will very shortly be inviting those who've agreed to monitor their mood on a daily basis and stressful life events over 3-4 weeks during term time. And then we will push out a third wave of the survey in July, so that will be a year after the first follow-up, and then do some mood monitoring and stressful life events in the summer. And that's all we have funding for at the moment. So bottom line, what did we find in July last summer? So the rates of probable mental disorder were assessed using the Strengths and Difficulties questionnaire, using a diagnostic algorithm that allows you to combine more than one informant when you have more than one informant, and it also incorporates the impact of problems rather than just putting a cut point on the difficulties. Now that's different to what was done in 2017, where we had this very detailed diagnostic assessment that involved a full interview with the parent, full interview with the young person if they were aged 11 or more, and if the family agreed, a questionnaire was mailed to their teachers, and a small team of clinical raters put the information from all three informants together in terms of assigning diagnoses according to ICD-10 and DSM-5, which you can imagine was quite an undertaking for over 9,000 children. So it was a very detailed, comprehensive assessment. Obviously, we couldn't do that at the speed we had to mobilise and the funding we could obtain last summer, so we just used the brief questionnaire. But it's more than just scoring above a cut point. To meet the condition of probable disorder, you have to have difficulties, and they need to be in the top 95th centile, and you have to have impact. And the bottom line is we went from 1 in 9 in 2017 using this method to 1 in 6 in the summer of last year. So a further deterioration. As with 2017, young women seem to be doing particularly badly. So there was an increase. It was 23% of young women were struggling. Of course, they were 17 to 19 and not 17 to 22 at that point. And that signal has come from other studies as well. So the adult survey program, which is affectionately known as APMS, has 3 very comparable arms, 2000, 2007, 2014. And that also showed a very large increase in anxiety, depression, and self-harm among 16 to 24-year-olds. So, and women in particular. So we need to think about what we're doing with our older teenage girls in terms of how we support them, because something is going particularly badly wrong with this age group. So, as I've hinted before, not everybody is having a dreadful time. So it won't surprise anybody that those who are likely to have a mental health condition report that lockdown is making their life worse, but about a quarter of the population are saying that lockdown is making their life better. It won't surprise anybody here, I don't think, that poor mental health in the parents, this is using the General Health Questionnaire, in 2017 and 2020 was strongly associated with a mental health condition in the child, and that it's increased. Likewise, family functioning. So much more likely to have a problematic family functioning. If you have a child with disorder, that was evident in 2017, as well as in 2020. And I should hasten to say that this is cross-sectional data, so I'm not implying causality. And in fact, I suspect it's a very complex bidirectional effect. And in earlier surveys, we've done some work that demonstrates precisely that. If you have a parent without mental health problems at baseline who has a child who has an anxiety disorder or depression, they're much more likely to be scoring high on this scale at follow-up, and the reverse. That slide's repeated, sorry. We also have stacking of risk factors. So what you're looking at here is all the things that you might need to access your online schooling during lockdown, by whether or not a youngster is unlikely to have a disorder in dark blue or probably has a disorder in silver. And I want to point to this group. There is a group of children who've really been excluded from education, who we need to really worry about, because these will be children who are facing other challenges. And what we will have seen is the growth of health inequalities, but we will also be seeing growth in educational inequalities. There is also stacking of other risk factors, which I think was highlighted also in Oxford. So there are a group of young people who are drinking more, gambling more, sleeping badly, all of things which risk mental health. They, in the national survey, they were associated strongly, cross-sectionally, with poorer mental health. So I think there are more risk factors as well as poorer mental health overall. The paper I have up here is using the UK longitudinal study to explore the impact of COVID early on. So that this was data from April, May, very early on in the lockdown. And what they showed, as you might expect, was those with poorer mental health to begin with were doing particularly badly. Girls, young women 16 to 24, but also 25 to 30 were likely to be doing worse, as were parents with very young children. And of course, if you work with families or you work with children, you'll all be aware of how the impact of poor parental mental health is not great for children. The same group has studied trajectories over time. And what they have found is these 5 trajectories. So the biggest group of people, and a high score on the GHQ is bad. The largest chunk of people are really doing okay. Either they had a bit of a wobble and bounced back, or they're, never really changed much. There's another group that reacted strongly initially, but then recovered. And then there are 2 smaller groups that seem to be either deteriorating slowly and steadily over time, or they reacted strongly initially and then have gradually improved maybe a little bit, but not much. You are much more likely to be in these 2 deteriorating groups if you are young, if you are female, if you're from an ethnic minority background, if you're living in socioeconomic hardship. And that means that as clinicians, they're groups we need to say. I didn't put a graph up because I was worried about death by PowerPoint, but in the national survey, there was a very, very strong association between living in a family that was struggling to meet household bills, and also an increase in families having to rely on food banks, with a similarly strong association with poor mental health in the child. So we need to be really aware of the number of families whose circumstances have deteriorated, who are often the families that are in the most challenging circumstances anyway, and the impact that that is likely to have on both parents and child mental health. There are hints from various studies, I think Kathy Cresswell's is one of them, that kids with pre-existing mental health conditions might be actually bouncing back less than the rest of the general population. The other thing that may play into this is that if life has felt a lot better when you don't have to go to school, when schools reopen, actually that can be a real challenge, and that may also be playing into mental health difficulties. And I think there was a lot of talk around, you know, quite a punitive, hard, we need to get children back, children need to be in schools. That's never going to help anxious families. Those families need support, they need to work in tandem with the schools, and it's really important to try and preserve the relationship between the family and the school, and for it not to become confrontational. We also should remember that many families will have had adverse experiences related to COVID. So a small number of children may have been really quite unwell themselves, or they may have been bereaved. And if you are living in a family under strain, you may have been exposed, much more exposed than normal, with less of your social support to abuse, neglect, or domestic violence or risky behaviours. So I wanted to talk about this work that has come from Helen Minnis's group in Glasgow University, where she was immediately, because of the group she works with, which are children on the edge of or in care, very concerned about how vulnerable families would cope without support, and, you know, often in inadequate housing and often with other constellations of difficulties. And what her preliminary work showed won't surprise anybody, that initially lots of people were very unsettled, but when she went back later in the summer, families were either in a virtuous circle where they kind of got themselves into a routine. They had managed to source the equipment they needed for everybody to either attend school or work from home. And actually they could see the positives of, you know, increased family time and less external pressures. Whereas those living in cramped condition, perhaps without Wi-Fi that's reliable, or without maybe one device or tablet or computer across the family, and no space to get away from each other, were actually often then in a vicious circle of more stress, leading to substance misuse, violence, and just things spiraling out of control. So working with infectious disease specialists, also people from the police, social care, mental health services and education, they've come up with this model of trying to protect these vulnerable families. So the ideal thing is that you keep the schools open as much as possible. But if cases are going up in the community and people are worried about transmission in schools, well, maybe we go to kind of Nightingale schools, where either you spread people out across more buildings, or people come in bubbles, and not for full time, but at least everybody gets to come into school sometime. And then if you have to go further, that you actually either provide a trusted childcare link in a small cluster, or you have some trusted relative who can do so, so that the families are not left struggling under pressure on their own. And that, you know, isolation at home without any social contact is the absolutely last resort. Thinking also about what can we do, this table comes from a practitioner review that colleagues and I did for the Education Endowment Foundation in terms of managing behaviour within schools. And I think, you know, schools spend a lot of time worrying about the red and amber boxes, and sometimes there's not a lot they can do about those. Sometimes it's useful to be aware of them and that you might be able to do something to influence, but actually there is a lot in the school organisation in promoting positive relationships within schools, having clearly and consistently implemented anti-bullying strategies, teaching problem solving, conflict resolution, etc. You know, having a school culture that promotes mental health and well-being is where, and particularly given that poor peer relationships seems to be a predictor of the persistence of mental health conditions once they occur, and considering how peer groups may have shifted as people have been out of the school environment and then are coming back in, I think those are the areas that schools should invest their efforts. So I just wanted to sum up by saying, you know, I don't think we are doing terribly well in the UK. We wait to see what the recent data, which is not publicly available yet, shows, but certainly in last July, we were not doing very, very well. But it was 1 in 6, so it's still a minority, and the vast majority of our kids have been able to cope and are being supported to cope. What has grown is this vulnerable group. We have more families living in more stressful situations in terms of poverty. We also have more youngsters who are scoring in the possible as in terms of the unlikely to have a mental health condition. So we're getting more kids whose mental health is at risk, and we've got a slightly larger clinical population who obviously need the support that we can offer them. And we know that CAMHS is not in the best of places, so we're going to have to get smart about how best we can support people. I've made my slides available and there's some references for you. I'd like to thank my colleagues who've helped me with this programme of work over the years, vast number, too many to individually thank, and I'll stop and take questions now.